So I'm Ellen Leahy, and I was with the Missoula City County Health Department for a whopping 38 years. Um, and I served as the health officer and the director for 32 years of that. And that should have given me plenty of time to come up with a succession plan. However, as you will see, comings and goings kind of are very individual and very based on circumstances. That said, there's so many ways to build leadership across time, your own leadership, the leadership team in your department. And so while we started talking out when we were planning, we talked about succession planning, and I was invited to join. I said, I never really got to my succession planning because I quietly told my board I'm going to be leaving. And within the next month, COVID arrived. So instead I stayed, and I would not call it a succession plan. However, building leadership, building teams, strengthening your department, can definitely talk about that. When you think of being in a job for 32 years, it's easy to say, wow, how could you stay in the same job all that time? And I actually never experienced it as the same job. If you really are open to change, and not only to your own leadership, but to leadership of those that are coming up into the department and others in the community, then it's sort of like that river. You never step in the same river twice, because it's always moving and it's always changing. When I look back now, since I didn't really have the formal succession plan that I had on my mind a month or two before the pandemic, in which I was giving my board and the department and myself more than a year to make this nice, smooth change. But I can look back at least to 10 years, when I wasn't even thinking of retirement except on a bad day. You know how that is, don't count the years. And I can look back on that, and I can see the times where major strengths and changes, and particularly leadership and leadership teams, happen. So that's the story I'll tell. I had come up into the health department from a division level into the health officer director role, and all the other divisions, and we have 4 of them, actually we lost all our management in the department at the same time. There was sort of a mass exodus for different reasons. And so we all came up together, and we didn't have a lot of mentors because everyone who may have mentored us was really gone. So we looked outside our department for mentors, for people that had been doing a similar job elsewhere. So I think that's a really good way to build your own leadership, and is by connecting to other departments. I mean, look who's here today. We've had a nice turnout here today across the state. And then after we built a lot of things in our department, making it not the same job every day, that leadership team started to retire, and I was the younger among that. And then pretty soon I saw myself with an entirely new leadership team. And I think that's really when my succession planning, even though I wasn't thinking of it that way, that's when it started. So I worked quite a bit in 2 ways. One was to mentor those that were coming up, and the other was to really learn from them, because they were younger, they were newer, they'd been looking at things from a different place in the department. And I was starting to get tired enough where I could sit back and listen some, which was a good skill to learn in older age. And that team then, even though they started at different times, they really formed. The other thing that happened at just about the same time was that we had a board that for the most part had been extremely stable, not rusty and old or dusty, but I mean stable, very high caliber. They knew how to work together, they knew how to disagree, and they carried a bunch of institutional memory. And that board started changing rapidly at the same time. And so I was a little bit frantic, like, how do we rebuild? Well, the only way you rebuild is, to renew So that really is when I was thinking, wow, I've got a lot of work to do in terms of rebuilding, renewing, and in some cases reshaping. And so that required a different kind of leadership. For me, that was more of a focusing into the department and then having the new folks often be the face and the leader in the community on a lot of different fronts. So I always encourage that, even if you're nowhere near retirement. So that focus inward, and right around the same time then, accreditation became available. And accreditation, I have to tell you, I went into it just with a blank stare, kind of a zombie look, like, okay, we'll do this and blah, blah, blah. And when I really dove into it, and I did dive into it, big time. That was the, it was fight or flee. It was join or don't do it. And so I actually became a convert. But with that, I think that was one of the things that strengthened the leadership, the overall public health system, everything. I mean, if you're familiar at all with the different domains, that we really took advantage of that, sometimes kicking and screaming, but we thought if we're going to do it, we're going to do it. And did quite well with that. And then, of course, you're never done with accreditation. You have to start right away in order to be reaccredited. So I'll be talking a bit about later on about how the aspects of accreditation, at least what it's aiming for, can help build your leadership. There's so many opportunities there. One of the things that I kept in mind as I got closer and closer to even thinking about retirement is I never wanted to retire in place. I had seen people in different jobs who retired in place. You know, they had 5 years to go and they wanted to keep things smooth, and and I just never wanted to feel like that piece of dead wood. And while that did exhaust me, it kept me thinking of what can I do to renew and to renew and to renew and to change. The other thing that really changed for me, in addition to accreditation, and this was all kind of going on at the same time, starting around at that 10-year mark, before I ended up retiring, is I actually went back for my MPH at the end, toward the end of my career. I had been operating on a master's in nursing that was designed particularly for a place like Montana, and it had a lot of community aspects to it and leadership in the community level, including more rural. And that was a huge renewal for me. So I just got sick of going to conferences. I didn't want to do that. I wanted to really have a sort of a path that was good for me. And that was such a nice available path. And it also created all these new leadership teams and connections. Many of, well, you can see what DPHHS and U of M has done, because we're all here with the training center. I mean, that is astonishing. So when it finally came down to it, I stayed rather than retire. I stayed longer, of course, because of COVID. And then the board went on its, and I didn't announce retirement. Only the board knew. We let that go. And then when I was watching how things were progressing, I set myself a goal of when immunizations came out and I could see how we progressed with immunizations, then I would feel better about leaving at that time. And so that's mainly how I did it. So I did not have a formal succession plan. By that time, though, our strong team that had just got reaccredited the month before COVID hit our shores. So we had just done our reaccreditation. We thought we were busy. We thought we were strong, and we weren't anywhere near as busy or strong as we were going to be. So we went into that, and that, of course, gelled all of us even more, right? It gelled us more across the state and within our departments. So instead of having a nice succession plan, when Deshane Barnett was hired, he didn't even shadow me for 2 weeks. And he was, pretty chill about it. I was kind of impressed. I'd say, okay, we're going to do this briefing. I'm going to do this one. You'll do it tomorrow. And that's it. It was see one, do one. And then I would abandon it. and dump out the office. And so we went from having what would have been a 1.5-year plan to no plan, really. But I knew that not only of his capabilities, but I knew of the strength of that team. I was worried about their exhaustion, of course. And instead of having something nice and smooth, and he just kind of came into the same environment that I would have left, it went, I think that forced us through that change, as it has across, in the country and in the world. When you look at the stages of change, you have to go through that unfreezing stage where things have to unfreeze enough that you can actually change them. Well, COVID certainly did that. So while it strengthened our leadership team and our capabilities, it unfroze kind of our environment and how they were going to go forward. And so instead of me leaving loose ends, the department experienced kind of a continental shift. And then I think they made the most of that. And I feel very good about the leaders and the leadership team. And from a distance, I've seen how they've just moved on with all the strengths that they knew they had. So while I miss it dearly and grieve it, I feel very good about that. But at the time when I was saying, here, Jane, I'll do this one, you do it tomorrow, and I'll do this one tomorrow, I didn't feel that way, but I certainly do now. So that's my story.
Thank you so much, Ellen. Who do we have next on our list, Des?
Okay, that would be me.
Awesome.
Good morning, everyone. I'm John Felton. I've been with Riverstone Health, which is the public health agency for Yellowstone County, in one form or another, back all the way to 1997. So I'm going to really kind of tell 3 succession stories here. I've been in organizational leadership in healthcare since I literally stumbled into it in 1987. I never set out to be an organizational leader. I was at a place in Cincinnati, and someday when we have lots of time, I'll tell you the whole story, but I'll give you the short version. A few months after I started working there, we discovered that an employee had murdered a patient. And in the end, that employee confessed to 24 murders at that facility, 17 murders at the hospital in the VA hospital in Cincinnati, 9 murders at a hospital in Kentucky, and 30 non-healthcare murders. So I was really interested in getting out of that organization. But who was hiring people from the place that killed patients, right? I also had a brand new baby, I had a brand new house, and mortgages and school loans and all that stuff. So I stayed. And after we went through 3 CEOs in a matter of about 4 weeks, I was given an opportunity to jump into leadership, and I've been there ever since. So in that particular setting, succession planning was, whoever was alive could take a job. The short story of that, and it's a really interesting story, but it's long, is we did a pretty dramatic turnaround of that organization. Then after about 6 years, our CEO retired, and I decided it was time to go somewhere else. So I ended up landing a position as the CEO of the Northern Rockies Cancer Center in Billings, which was a small, about 35 employee, I think initially we were about $3 million a year, radiation therapy center. It was a nonprofit corporation jointly owned by the 2 hospitals in Billings. So they can cooperate about certain things, and that was one of the areas they cooperated. And what we did in that organization, we built it up some, and the time came to restructure that organization. And what it really was going to do was become part of a more integrated part of the hospitals rather than a standalone entity. So part of what I did as I was working through this was recognize that organization really didn't need a CEO anymore. What it really needed was a manager. It was going to be largely controlled by the hospitals and their strategies. So I restructured that position and then left and came to what was then Yellowstone City County Health Department. My initial interaction with this organization was how I was still at the Cancer Center. And in 1997, there was a change in the state law during the legislature that allowed this entity, well, it actually allows any public health entity to restructure. So as you all know, most of the larger communities in Montana have city county health departments. And those are created under interlocal agreement that essentially says, you know, we both have public health responsibilities. We're going to do it together, and we're going to have one organization, one department, and it's going to live in the county. And that's the way we were structured up until this point. So the organization was a part of Yellowstone County. The employees were county employees, just like, you know, other local health departments in the state. What that legal change did was create a new interlocal agreement that is very similar to other ones, except for one gigantic difference. And that difference is that the interlocal agreement that we now have creates an entity. So Yellowstone City County Health Department stepped away from the county structure. Our employees were not employees of the county. The county commissioners didn't control our budgets and things like that. Excuse me. And so now we have an entity, right? We have a board that is a governing board, not a policy, not just a public health policy board, but an actual governing board, because it governs an entity. So while I was at the Cancer Center, I was part of the group that created that structure, a community group. Then I went on the Board of Health for 6 years. I came to work here in 2004 as the Chief Operating Officer. Many of you have probably know Lil Anderson. Lil was with this organization since 1976. She was its executive director or CEO since 1992. And this was kind of the first real succession plan that we had. Was Lil wanted to retire, and in her mind, I was her succession plan. She wanted me to take over. And so I came to work here in May of 2004 as the Chief Operating Officer. Lil was the CEO. When we separated from the county and created an entity, we opted to go with more corporate titles, so CEOs, CFO, Chief Operating Officer, those types of titles. One of the things we always understood, though, and I think this is a really critical part of understanding succession planning, is we have to understand whose decision it is. So as Ellen talked about, we can identify people that, you know, we're prepping this person to move into this role. If we've got, let's imagine a situation where we've got in our world, let's say a program director that we think is going to move into a vice president role. That, as a CEO, that would be my call. Okay. So I can prep that person. I can decide, okay, you're ready, I'm going to make the move. When you're talking about the top position, it generally is not, it's not the decision of the people who are there who's going to move into that role. And Lil and I always understood that although I was her succession plan, it wasn't her call. Again, I'll spare you the details, but we have a really weird structure here. The CEO position here actually reports to 2 boards, is selected by 2 different boards. We have a total of 5 boards that we deal with here. The CEO reports to 2 and sits on the other 3. But we always understood that, although again I was Lil's succession plan, it was the decision of those 2 boards. So Lil had been here since 1992. There was no search when she became the CEO because she'd been here since 76 in other roles. And as she started talking about retirement, the boards were getting pretty anxious. They'd never done this. And so we worked together with the boards and created a succession protocol. And it really is a protocol that's specific to our organization because of its weird structure. So again, the CEO job reports to the Board of Health, and also reports to the Community Health Center Board. So there's a series of questions that are asked. The first question goes only to the Board of Health. And that question is, do you want one person to be the CEO of Riverstone Health and the health officer, or do you want to split that role? Because as you know, in many departments, those are split roles. Someone's the director of the health department, someone else is the health officer. The second question goes to the Board of Health and the Community Health Center Board. And that question is, do you want one person to be the CEO of both those entities, or do you want to have 2 different people? So in Ellen's case, in Missoula, the Health Center Board chooses its executive director. The Board of Health chooses the director of the health department. In our organization, from the time Lil took over, that one person reported to both those boards and was the CEO of both those entities. Then the third question goes to both of those boards because they're the decision makers. Do we have an internal candidate that we will consider, or do we need to do a search? So I came here in May of 2004. Lil intended to be here for 1 to 2 years. She stayed 7. So I was the chief operating officer for 7 years. Lil was not around here a lot. She had a really prominent national role in the community health center world. So she was gone a lot. So when she made the decision she was going to retire June 30th of 2011, the boards went through that process. And so they asked the Board of Health, you want one person to be the CEO and health officer, or do you want to split it? They said, we want to keep it together. Went to the 2 boards. Do you want one person to fill both those CEO roles, or do you want to split it? They said, we want to keep it together. Then the third question for those boards was, do we have an internal candidate that you want to consider, or do we need to do a search? And I was not in the room for this, but several people who were told me both those boards were sitting around a big old table, and they went person to person and said, you know, I was the person who was the internal candidate, but do you want to do a search? And this was with no staff present, so they could be perfectly honest. In the end, they all decided not to do a search, and I was appointed. Here's my little parenthetical statement. That was going to be a really smooth transition because I'd been here for 7 years. Lil retired on June 30th. I took the role on July 1st. July 1st of 2011 was a Friday. I'm not really kind of a center of attention sort of guy, so I was glad that I could make this move really smoothly. So on that Friday, I moved into the CEO office. We had a 3-day weekend coming up, right? So it's Friday before the 4th of July, which is Monday. A lot of people are already gone on that day. 4th of July is Monday, got a 3-day weekend. By the time everyone comes back, no one will even notice that the change happened. That was a really, really good idea for about 22 hours. Because at 10:30 that night, an oil pipeline burst in the Yellowstone River, spilling 60,000 gallons of crude oil into one of the most pristine rivers in the United States. And that was my first weekend as a health officer. Okay, fast forward through all these years, and I made the decision that I was gonna retire. I originally planned to retire at the end of fiscal 24, which would be for us June 30th of 2024. I wouldn't say that I think COVID literally shortened my life, but it did make me want to retire a little earlier. So I made the decision that I was going to retire at the end of 2023. Now, one of the things we always have to think about in these types of successions is what is the experience of the decision makers? So here's our experience, right? We have literally a one-of-a-kind organization. There's no other entity that is structured the same way we are in the state, where the health department is a separate entity. And it's got this, you got the health center in there, and you've got home care and hospice and residency and all this stuff. They had 2 CEOs over the course of 30 years and didn't search for either one of them. Okay, so they're anxious. I was originally asked to give 5 years notice before my retirement, and I said no. I tried to work them down to 1 year. Literally, the best I could get was a 3-year notice. So in December of 2020, I informed the boards that I was going to retire at the end of December of 23. The reason they wanted that long notice, it was largely anxiety because they'd never done this, and they wanted to make sure there was a period of overlap with the new CEO and me. So I gave the announcement. We went through a search process. We got down to 2 candidates. The boards offered the position of one of those 2. He took another job, did another search. And in August of last year, John Forte was offered the position of CEO. Now, there's also been another change, right? So the boards went through that 3-question scenario. Then in the middle of this, we have House Bill 121 in the 2021 legislature that says the Board of Health no longer gets to choose the health officer. The Board of Health makes a recommendation to this local governing body, and that body actually makes the decision. So the boards were very upfront with John Forte about this and said, what we want to hire you to do is be the CEO of Riverstone Health, the CEO of the health center, and the health officer. We can't promise you that last part. That's our goal. That's what we want to do. That's the structure we want to keep, but we can't promise it. So the decision was made that I would relinquish the CEO roles when John arrived in January. I kiddingly tell people that the main thing he had going for him was his initials, because that way we wouldn't have to change the monogram towels in the executive bathrooms. There are some people who actually believe that's true, and then they realize what an absurd idea that was, but the two JFs do work. So at this point, and I realized this just the other day, for the first time since 1985, nobody reports to me. It's kind of a weird feeling. It's not a bad feeling by any means, but it's kind of weird. So John arrived January 3rd of this year. One of the things that I actually said to both boards and to the senior staff, and this is really important, is if you're going to have an overlap in transition, particularly the leadership, you can only have one CEO, or whatever you call that, executive director, director of the health department, whatever you call that role, you can only have one of those. And it's really important that the boards and the staff understand that John Forte is the CEO and I am not. And so I encourage them, when you communicate with John, don't blind copy me, don't carbon copy me. If he has a question, he can ask. But what you don't want to do is create an environment. If you're in that overlap situation, you don't want to create an environment that makes the person feel like, am I really in charge or am I not? Because then you lose the confidence that they need to have. So I retained the health officer title, partly because I need to have some job while I'm here, and partly because John's not ready for that, and we don't have a process to make that change yet. So the intent is at the end of the year, we'll recommend that he become the health officer, and then that will go to that local governing body. So this is a really unusual transition. When we talk about transition process, and I'll talk a little bit more about this, but it stretches out the period of uncertainty. I still get people who will say, like, can I ask you a question? I'm sure, it's fine. I won't answer as the CEO, but I'll answer as me. So it does create a certain amount of uncertainty with staff. The last thing I just want to mention kind of quickly is I want to follow up on something that Alan talked about that I think is really critical. And that's the idea of retirement in place. I don't want to do that. Clearly, Alan doesn't want to do that. But there is a period that I've come to realize that I think is really important. I've watched kind of multiple ways that people have retired or left an organization. There are those who retire, as Alan said, 5 years before they leave the job. They're just sort of filling space and not really, they don't want to take on any big projects because they're just sort of putting in their time. That's a problem. That's a problem largely for the organization. I've also seen people, and I have one particular, we had a director position, a senior director position, who went full speed, 100 miles an hour till 5 o'clock on Friday that she retired. And she was gone. So, we always talk about how important it is to have staff engagement. What I would say to you is, as you're looking at particularly retirement, there needs to be a period of controlled and managed disengagement. And it's kind of a dance. Again, you don't want to do it 5 years or 6 years out, but it's not healthy for that person to go to work on Friday like it's any other day and wake up Monday like, what the heck do I do now? I don't know anything. I just know how to go to work. So I think there's a certain amount of grace that you need to accommodate with your retirees that allows that sort of gradual, not excessive, not destructive, not harmful disengagement to the point that for that person's mental health, they really are ready to move on to the next step of their life. So it's a bit of a dance, but I do think that's important if we're looking at the interest of our people who are doing this. They need to disengage a little, and so that when they wake up Monday morning, they're not sort of lost in the world. So with that, I will stop and we'll talk more later. Thank you all.
Thank you so much, John. I appreciate your stories and your sense of humor. Who do we have next? Is it Kim?
I think it's me. Yeah. Okay, so I come from a very small health department compared to the first two that we're talking. So I'm Kim Berg. I live in Havre. I am the director and health officer for the Hill County Health Department. I have been working in Hill County at the health department for 13 years. I first started as the program assistant, and I was brought on specifically to do the community health assessment and community health improvement plan for the county. So that was my first big job. And then I was given some more jobs, such as the vaccine manager. And I managed that program for 5 years. And I was that program assistant for 5 years. Along with that, I worked very closely with the director on the budgets, and I helped her do all of her budgets and everything like that. So I did learn directly from our director at that time, because she just didn't like budgets and numbers, and it was hard for her to wrap her mind around there. So I helped her with that. When she chose to leave our health department, it was 2015, I believe. She had given us about 2 months notice. So there wasn't a big succession plan in place, but she had told me that she would like me to step into that director position. This was going to be a big change for our health department and our county, because up until then we had had a nurse in that position, and I have a bachelor's in health promotion from MSU Bozeman. So I also now have my master's in public health from the University of Montana. And I had taken it upon myself also to sit for the national certification test to be nationally certified in public health. So I'm a CPH through the National Board of Public Health Examiners. But it took a lot of meetings and education to our Board of County Commissioners, as well as our Board of Health, for them to understand that it doesn't need to be a nurse in that role to do the budgets and grant applications and grant reports and oversee the health department, because that had just been the norm across the state, really. But we were doing that shift more towards health promotion, community health work. And so they finally bought into it, and I got the director role in April of 2015. So I've been the public health director for the Hill County Health Department since April of 2015. We have had around 11 people in our office. That was usually the most that we would have. Currently, after the pandemic, we are down to 5 people in our office now. We'll get more into that, but I want to say, I think a lot of what has come out of the pandemic is the importance of succession planning for us at the health department in Hill County, and the importance of cross-training the duties between all different staff. So in 2020, when the pandemic hit us, we have a lead public health nurse who's been with us for about 20 years. She is by far, in my mind, the best public health nurse in the state. I would take her over anyone. And we are very lucky to have her still. She knows communicable disease inside and out, and could take that COVID-19 pandemic and run. The issue that we had is that we had 2 other public health nurses that were trained in contact tracing, case investigation, and communicable disease at that time. And that was not enough for the increase of work that we had seen. The issue that we had is that we thought we could handle it, right? So we were working 15 plus hours a day, 7 days a week. And we did not make clear decisions on, this is how many hours you're working, and then you are off the clock and you are with your family. That is one thing that I would very much stress moving forward, that if there is another pandemic that comes, knock on wood, I don't want to be here for it, but if there is, we will have very clear expectations of, you are off the clock at this time and you are living your life with your family. Because the level of burnout that we saw, and the decrease, like the big drop in morale of what we truly do in public health has been huge for our department. We are lucky to say that everybody that we still have has been here through the entire through the entire pandemic. So not everybody left, but we have had half of our staff leave. We have had funding cut from our county because they don't necessarily see the big importance of us needing that many workers. I think the education to commissioners is very important on what public health is. And the fact that if you see one health department, you've seen one health department in Montana. We are not all the same. We don't all have the same programs. And I'm running into that with our commissioners, is that they truly reach out to other health departments to see what they do and then tell me that I don't need to be doing what I'm doing, rather than looking at what we're doing in our community. So we are reorganizing our health department. I have fought to increase our wages. We were one of the lowest paying counties in the state. And as of about 2 weeks ago, I finally got the approval to up everybody that has been here. We have a minimum of 7 years experience with everybody that's been here at our department, which I think is huge, and we needed to acknowledge that. So that's a big win for us, but we are only guaranteed right now 5 positions at our health department. We are only 20% funded through county funds. The rest is grant funding. And if I am going to bring on more staff, it has to be grant funded moving forward, which is not unheard of in public health world. But I am still trying to get more of a buy-in and a support from our county commissioners. There is a big disconnect between what we do, the importance of what we do, and just still trying to fill that void. I became the health officer for Hill County in the middle of the pandemic. I became the health officer in October of 2020 because there was some political fighting basically between the hospital in our community and public health, and the provider that we had as our health officer up until then was basically told that she needed to cut ties with the health department. There was no succession planning for this. It was very abrupt at the end of September, and our Board of Health appointed me the health officer based off of my experience and my education. I did not have my master's at that point, but I was in grad school. So I was basically just thrown to the wolves, and here you go. Luckily, our previous health officer is a close friend of mine, so she was willing to kind of help me, guide me some during that pandemic. But ideally, that succession planning for that health officer role is so huge and important. And I try moving forward with our health department as we're reorganizing and cross-training. I'm trying to kind of get all of our staff understanding that important role of the health officer. Like John had mentioned, we have a sanitarian who has retired 5 years ago, but he's still here filling in basic needs. And we're not getting what we truly need from a sanitarian. And so that is a problem, right? I understand what he's trying to do is help us meet what we need to do, the very bare minimum of what we need to do, but it's not a positive for our department, and it's not a positive for our community. So I think that succession planning of, if you're planning on retiring, and he knew he was retiring, but we just haven't been able to find a sanitarian. And I know that's a statewide issue that people are seeing, but we are also fighting that you need to post it at a higher wage. Currently, I believe our sanitarian is posted at $20 an hour with a license, and you're not going to get a sanitarian for that wage. So working on the importance of these positions and getting our county to understand that is real essential, especially in succession planning. Because like we all know, you can't just find qualified staff to step into these positions. So I have been the health officer and director for the department for about 2.5 years now, since October of 2020. So total of 13 years with public health. And now our county has chosen now to combine those health officer and director positions for our department. I think it's worked really well. We are a close health department. We're very small, but we all are very willing to help each other out. And I think that cross training on the different programs, everybody in our health department is trained on contact tracing and case investigation. We only have 2 people who are able to get into MIDAS, the state system, but we are all able to step in if we have an outbreak of pertussis or if an investigation is needing to be done. And we are all very willing to help out. So I could probably leave it at that and then just answer questions going forward. But we are working on a succession plan, like a concrete actual succession plan for our health department. We don't have it in place yet, but that is definitely something that we want moving forward. So. Yeah.
Excellent. Thank you, Kim.
Yeah.
We're going to pass the torch to Hillary.
Hi, everyone. Hillary Hansen with the Montana Public Health Institute. I'm apologizing up front that I have a bit of a cold, so I'm going to attempt not to cough, but you might see me taking lots of drinks here. When I was asked to do this, my answer actually was, I'm not sure I should be the one on the panel because I was part of good succession planning, but I personally did poor succession planning. And so I'm going to share both sides of kind of what has been my story from a succession planning standpoint. So I, prior to the position I'm in right now, was at the Flathead City County Health Department. I came into the role at Flathead City County Health Department as the Deputy Health Officer, and that was a new position that was created by Joe Russell, who was the health officer there. By the time he retired, he'd been there, I think, about 25 years. And Joe really set it up as, I know I'm going to want to retire soon, and we need to create a position to prepare them to take over the health officer role. So some of, to me, the really incredible pieces that happened in that piece, number one was naming it Deputy Health Officer. It set it up from a kind of from the go ahead as this understanding that it was meant to be kind of that backup position and potentially viewed, at least by some, as succession planning. The other pieces that were put in place to make sure that that's how that position was really working, one was an actual policy with the Board of Health. And so the Board of Health in Flathead wrote a policy that said, in the absence of the health officer, the deputy health officer takes on those legal, that legal authority. And so that was in place as this backup piece. And then from a day-to-day perspective, the position was really treated as a learning position. I think that I had tons of actual work I had to do too, like I managed some of the specific programs, but in addition to that, it was really about making sure that I had a seat at the table for everything where I could possibly learn, and then eventually transitioning into taking lead of those things. So examples would be like Board of Health. We would have staff come to Board of Health meeting and kind of sit in the audience, and the health officer sat at the table with the Board of Health. I, as the deputy, sat at the table with the Board of Health. Commissioner meetings, same thing. Like a lot of times, even the commissioner meetings were passed off to me to be the lead of, so that I can learn those pieces. Union negotiations, HR pieces, those were all just the pieces that Joe really took the time to bring me into, so that by the time he was ready for retirement, there was really nothing that felt like a mystery to me. Was I nervous about doing some of those pieces? Sure, but I knew what the day-to-day job would look like. And during times when Joe would be on vacation or sick leave, it was actually set up as Hillary's in charge. You go to her. If she needs me, she'll contact me, but none of you are contacting me. And so it put me in a position to really learn and grow and have the conversations I needed to have with him as I made those decisions, but for staff to really start to view me in that position too. And so I think all of those were really helpful. We were lucky in the position, while I was never guaranteed the position, kind of similar piece to what John was talking about, of I was viewed by Joe as the next health officer, but it was not his decision to make. And so I considered myself a little bit in a 5-year job interview. But when it actually came time to do it, because of the way the position was set up, the HR office agreed, and I always like to say this because this is a county too, the HR office agreed that the position was meant to be a succession planning position. And therefore the board had the option available to them to hire me directly if they so chose to without posting the position. And that was what they chose to do. And so that was a really great process, one honestly that I didn't anticipate. I thought that it would be a full hiring process. But that was a great thing that then the county HR was also able to get on board with. So I kind of stepped into what I would consider maybe a long transition process, but a really great transition process of really understanding what the role would be and knowing the staff, having the staff even see me in that role before Joe ever stepped out the door. On the flip side, when I left, we weren't in the same position. And I think there's multiple reasons for that, but a few I really look back on, and some kind of I started to try to change before I left, but didn't have the time to do it. But a couple things that happened, even as we were looking to replace me as deputy health officer, the way we had the management structure set up at Flathead, we had very few mid-level managers and mostly kind of the actual supervision, HR budget, whatever, laid with Joe and I. And so what happened when we went to go hire to replace me as the deputy health officer, you read a job description that says somebody has to have a minimum of 5 years of supervision. We had never given that opportunity to anyone within the department. And so we were in a position where we had created a job description that basically job description and organizational chart that didn't ever put anyone in the position to ever be qualified for that position. And so we started changing that early on when I took over as health officer, of creating management level positions. But that was a big downfall that we had, that I would redo over again if I could. And I'd even go back and reread all the job descriptions to understand what the qualifications for them are. I also think my departure was a departure, not a retirement. Like, I resigned. I chose not to renew my contract. And so it's one thing to talk to your staff and talk to your board about a retirement. It's a whole other piece to be talking about just departure. And I think we've had the tendency to make some of those subjects taboo. Like, kind of like, if I mention I'll ever leave, they'll take things away from me, or they won't give me opportunities, or whatever the conversation is. And so we get ourselves in these positions. And I think now we're seeing people not stay for 20, 25 years anymore. And so for me, it's really also about changing that conversation to, it's not about asking people, are you going to leave, or when are you going to leave? But like constantly having that conversation about, you know, how do we prepare for people to leave? Maybe it's because they won the lottery, maybe, you know, who knows what it'll be, so that we're not left with thinking of succession planning just as something we talk about from a retirement standpoint. So those are kind of the two pieces as I look at my story of like, what happened right for me, and then also what I didn't do correctly in that scenario. Excuse me. So in my position at Flathead, it ended up taking them, I think, over 2 years to actually fill the health officer position. Yes, some of that was COVID and maybe the politics that came with it. Like, I don't want to downplay that piece happened, but we also were in a position where we hadn't set up internal structures. We hadn't created that leadership and management from inside to be able to fill those gaps and start to look at those positions too. So I would consider myself both the like good story and the bad story of what succession planning could look like. So I know we're nearing the end of time, Emily. I didn't know if we wanted to do questions right now or if I can always talk more, but trying to save some of it for later too.
For sure. And save your voice a little bit. We got to keep you for 4 hours. I think we have a couple minutes if there's any burning questions, and then we'll slip out on a break, and we will have time later in smaller groups with these folks to ask questions then too.
I will say one more thing that I forgot to share, because I feel like John Felton wisdom always goes a long way, and John is like, I have no idea what you're talking about right now, Hillary, but I will say one of the pieces John said to me when I was going to Flathead was like, kind of the plan was, I'm going to get there and Joe's going to retire in a year or two. And John's words to me were, when you get there, you automatically make their life easier. So remember that you may be in that position longer before the person retires. And I only share that because I think it got me through something that went from being 2 years to 5 years. And B, I think even as we're talking about succession or you're talking to staff about it, being really honest with yourself too of, yeah, you may want to leave in a year or two, but are you really going to leave in a year or two if somebody's able to help you with this, this, and this? And so kind of preparing people maybe a little more realistically for what a transition will really look like. So that always stuck in my mind, and John probably doesn't even remember that conversation, but it had a big impact on me.
That's definitely a good point. Well, it's now top of the hour, so I say let's take our 10-minute break. So grab a beverage, get up and do a little bit of stretching, and we will be back at 10:10. We will kick off our next section with John Felton. And as our agenda says, on organizational change and transition, a leadership perspective. So whenever you're ready, John, you can share your slides and off we go.
All right, thank you, Emily. Welcome back, everybody. What I'm going to talk about now is I think one of the things that has dramatically changed my particular approach to leadership. I learned about this way back when I was in grad school in Cincinnati, and it's a way of looking at change, because we always hear change is hard. And I'm one of those people that I'm never entirely sure. Oops, I think I just messed up. Okay, there we go. I'm not entirely sure why change is so hard. What I do know is that people adapt to change and respond to change very differently. And this model is something that I think really helps explain some of that. So let's start with the cliches. The most common one we hear is the only constant is change. The similar one to that is change is hard. Nobody likes change. The one that comes out of this model we're going to talk about, it says change is easy. It's the transition that will kill you. And I think when I began to understand this model, a whole lot of organizational dynamics began to come and gain clarity and start to make sense. So we're gonna spend a little time talking about this. First, let's talk about change management. because this is a hot topic. We obviously live in an extremely dynamic environment. In any sort of healthcare, there's a lot of change happens. That could be driven by technology. It could be driven by new expectations of how things are done or how you get paid. So value-based care, where healthcare providers are going to get paid for the results they produce in the population they're responsible for, as opposed to just doing services. I remember back when ACOs, accountable care organizations, were going to be the answer. I got a chance to hear the guy who actually invented the ACO concept. And he said, ACOs are like unicorns. Everyone thinks they know what it is, but no one's ever seen one, much less ridden one. And I think a lot of change is like that. Someone writes this learned paper that says value-based care is the way to go, or we deal with new entrants into our world like social media. One of the things that I noticed during COVID was I had no idea that Yellowstone County had that many epidemiologists, virologists, and immunologists. But there's lots of expertise out there because they all emailed me and called me and wrote on social media and all that stuff. So there's lots of factors that create this environment of change. So when you're talking just about change management, we're not to transition yet, but just about change management, there's this 4-step process. So first of all, you need to identify the need for change. What's the problem? Why does that problem exist? What doesn't work? What might work? This is really important. Sometimes you have a solution in search of a problem. That's not a very good way to do change management. I think some of the things we've seen in public health during the politicization of the pandemic was really a lot of solutions in search of problems. But you need to know really what doesn't work. What are we trying to fix? The next thing you need to do is decide what change you're going to make. And I think intentionality is really critical in any change initiative. If you're not intentional and transparent about it, change just looks random. So imagine, let's use a healthcare example of value-based change or value-based payment. So instead of paying for every service we produce, we're going to get paid for the results we produce for the population of patients. If we don't understand why we're changing into more population health management, more panel management, more telehealth visits, more case management, that just looks random to people. And they're like, why do we keep changing things when we don't have any particular reason why? So we need to be intentional in what our solutions, what we're trying to fix, what we're going to do. And we need to be really upfront about what are the goals we're trying to accomplish. Like, how do we know if we do this? What does success look like? But also, what are the barriers? And those barriers are always out there. Even if we think, oh, everyone's going to love this idea. Part of it is some people just don't want to go through the process of change. Part of it is people get really rewarded for what they've done in the past. Again, I use value-based care because I think that's a really easy example. So if you were a physician in the old days, you got paid for cranking out patients. Well, in a value-based care environment, you don't get paid for cranking out patients, you get paid for cranking out results. So that may mean, I don't want to see you every week or every month. I want to see you every quarter, but I want my nurses and my care managers to talk to you every couple of weeks. So we need to know what those barriers are and what does success look like. Next, we have to implement the change. This is where transparency is really critical. So we need to make sure everyone knows what is it we're trying to accomplish and what does success look like. And we have to know what our strategy is going to be. There are times that top down is the best way to go. Most times I think bottom up works better. But I mentioned I was in that weird situation where we had an employee murder 24 patients. We were on that organization was on a 23-day track to Medicare and Medicaid decertification, which meant pure insolvency. That is not a time that you gather around and have focus groups and you have an icebreaker activity and talk about how everyone's feeling. You say, we're going to do this right now, and you can do it this way, or you can leave, and I don't really care which. that particular entity, we discharged over 400 employees in the first 12 months. So that was very top down. It's not my preferred way of doing things, but you have to recognize the circumstances. Bottom up is usually better if time allows, because that means you have the people who are actually doing the work are driving the change. They know it better than any of the rest of us. What's our timeline? How often are we going to monitor our progress? If we're talking about a wholesale change of care processes or organizational structure, that takes longer. But we still need to have some steps along the way that we say, you know, by this date we want to be here, and by this date we want to be here. Who's going to drive that thing? Often, particularly in a bottom-up trend change process, the drivers are the frontline people. They're the ones telling you, you know, we tried this and it didn't work, so we need to do this. In a top-down situation, then of course those have to be the drivers. They have to be the champions. And I think there's a difference between drivers and champions. And it's really what their role is. Drivers are kind of the hard charging, we got to do this, we got to do this. Champions are all about the why. You know, we need to do this because this is important, because, and that why has to matter. It has to matter to the people who are involved in this change. So if I tell you we have to make this change because if we make this work and we make a lot more money, I'm going to get a much bigger bonus at the end of the year. For the record, I don't get bonuses. But if I did, you know, that's probably not going to be very inspiring to people. Oh yeah, let's work really hard and do all this stuff so that John gets a big bonus at the end of the year. Probably not going to be very effective. If the real reason you're making changes is because it improves care, it improves the health of your community, it improves working conditions for your staff, it makes the work you do more rewarding, people will get on board with that. So the why always matters. It's too often forgotten, but we got to make sure that those champions are really out there saying, don't forget why we're doing this. My wife is a dear lover of affirmations, and she's got one in our house that I look at a lot. And I thought about this a lot during COVID, which is when you're ready to quit, remember why you started. And I think in big change initiatives, that's really important. You got to remember why you started this. And then the last thing you have to do is evaluate the change. Why are we better or worse? Not every change is going to result in doing things better. The key to every initiative is, what do you learn from it? Can we take another step that makes things better? What would we do differently? So evaluation, I think we need to get away from the idea of pass fail. So, you know, if we said we're going to implement the XYZ program in the next 6 months, if the XYZ program is implemented, then are we successful? Maybe we're not. Maybe it was the wrong program. Maybe we're not doing it very well. Maybe we're not doing it in a way that's rewarding to our staff or to the people we're serving. So I don't really like pass fail measures. Another one like you often hear is improve employee satisfaction. Well, if your employee satisfaction, 10% say they're satisfied with their job, and you move that to 12% after your 6 months worth of work, is that really better? Well, if your goal was to improve, then yes. So I think you need to be more specific, but get away from that just sort of pass fail. So that's change. Those are the basic steps in any change initiative. What I want to talk about is transition, and this is really this book, Managing Transitions by William Bridges. I don't think there's a lot of things that I've read through the years that have had as much impact on me and my leadership as this one book. It's a really simple little book. It's actually in the form of a workbook, but it really is, I think, a huge boon to leadership. So the idea here is that change is an event. So in this case, we're talking about succession planning. So a new health officer, a new director, a new manager, whatever that changes. Other ideas can be like when you start a new job, or when you move to a new building, when there's a new county commission in place. Anything that is an event is a change. the key to this model is that everyone experiences the same change. So if you're going to bring in a new director and health officer, everybody gets that new director and health officer at the same time. If you're going to move to a new building or implement a new system, everyone gets that at the same time. So the change itself is relatively straightforward and consistent. Transition is how do you accept that new reality? How do you accept and move forward into this new environment? This part though, and this is what I think as leaders we really have to understand, is very personal and it's highly variable. Everybody goes through transitions at their own pace, in their own way, and you can't manage transition by policy. So you can do some things by policy, right? And I use that term sort of loosely. So as of Monday, I'll be gone and Jane will be the new health officer. Have a great life. I've enjoyed working here. Thank you very much. When everyone comes in Monday, Jane's the new director and health officer. That change affected everyone's same. How we respond to that change is going to be highly variable. So let's go through these 3 steps. The first stage of transition in this model is called letting go. And this is a realization that whatever we knew is gone. So let's use because we're talking succession planning, let's use the boss situation. So we have a new director and health officer. Everyone knows that the old one is gone. Now, I would point out in the situation that we have here, I'm not physically gone, but my role as CEO of Riverstone Health is over with. That means that I don't have the same authorities I used to have. That means I don't have the same roles. The reporting structures are different. That's over and done with. So we'll talk about our particular transition here. So the change is John Forte is now the CEO of Riverstone Health. I am not. My reality is gone. There's going to be a new reality because John's here. But we don't know what that looks like, which brings in this fear of the unknown. I can tell you that having been a part of the search process, John Forte, I believe, was the best candidate. I think he's going to do really well here. I know him better than most people do because I was part of that process. For those folks who are out there, they don't know him. They might have seen him on a Zoom meeting when he did a staff meeting during his interview process. He's been out and about doing he spent 3 months doing sort of immersive orientation to the programs and services of Riverstone Health. Most people don't know him. Most people don't like what they don't know. It scares them. The essence of this, of the letting go phase is grief. And this seems a little weird, but let's just kind of talk through how this becomes grief. When we grieve, what we really grieve, we grieve the loss of something we know. So let me say about my mom. My mom died January of 2022. She was 96 years old. My dad died in 2000. They were married for 53 years when he died. So she spent a long time alone. She was way ready to go for a long time. My mom was in assisted living in Seattle when the pandemic hit. Long-term care in Seattle is where the pandemic came ashore in the United States, killed a bunch of people. She spent 18 months in her room, basically by herself. My mom, I'm convinced every morning my mom woke up, opened her eyes and said, dang it, I'm still here. But when my mom died, there's a loss that I feel, right? Even though I know that it was something that she was ready for. So grieving happens because we lose something that we have. The key to transitional letting go is it is entirely unrelated. That grief reaction is unrelated to whether we like or dislike the old. So the letting go process in a succession has nothing to do with we really liked the person or we didn't like. So I'm sure there are some people who liked me as the CEO of Riverstone Health. I'm sure there are some who didn't. They all though go through this process of grieving, not because they think I'm the greatest or they're going to miss me or anything like that. It's not related to the value of the loss. It's related to the loss of what we understand. So we've all had those bosses that like, don't talk to Susan until she's had 2 cups of coffee. She's just a crab. She doesn't listen, just stay away from her. My first healthcare job, I was a 17-year-old nurse aide at a nursing home in Pasco, Washington, where I grew up. That was my first entry to healthcare. I worked evening shift because I was still in high school. We had a charge nurse named Roxanne Wakajance, and I loved Roxanne. She taught me so much about what it means to be in healthcare, what it means to take care of patients, what it means to really care about people. This is, I'm old, right? So this is back in the day where nurses wore caps. And Roxanne, the cap is tied to where you went to nursing school. And wherever Roxanne went to nursing school, their cap was like a little, it's called a stovepipe. It was basically like a little round thing that sat on top of her head, a few inches high. She also had curly hair. When Roxanne walked and that cap bounced, everyone found a room to be in because she was mad about something. If her cap didn't bounce, you go to her and ask her whatever you want to ask. If you see the cap bouncing, it was like, oh boy, find a room, look really busy, stay out of the way, because she was mad about something. So that is what we understood about Roxanne. We understand the boss we have. It doesn't matter if we like the boss or not, we understand. We understand how our computer systems work. We understand how to get around in a building. We understand what my current job is. When those things change, now we don't understand it. We don't know what's coming next. And so I think we tend to think about grief as the loss of something we love. In this particular context, grief is about the loss of something we understand. And even if we don't like that boss, we don't like that system, we don't like that building, we don't like, the elected officials, we don't like the city administrator, whatever it is, we understand them. And when that understanding goes away, that's what we grieve. So that brings us to the next stage, which is called the neutral zone. I will tell you up front that most people hate the neutral zone. It's uncomfortable. And here's what happens. The neutral zone is the time of greatest fear and greatest creativity, and it's for the same reason. There's no rules. Even those of us who think we don't like rules, we understand rules. Rules essentially create the box within which we work. So here's a non-work example. If you go to church at a church for a long time, you discover people sit in the same place, right? So you know that the Jones family sits in the 3rd pew on the right. If someone new comes in who doesn't know that and they sit down in that pew, watch where they go, oh my gosh, they sat in the Joneses pew. When the Joneses come in, they have this sense of, well, wait a minute, that's where we sit. Now what do? You go and to that person who's brand new and just showed up, say like, you're sitting in my pew. There's no name there, but everyone knows it's my pew. What do you do with that? Like, you don't know how to react to that. If I've been in that church for a long time, I know I don't sit in the 3rd pew on the right. That's where the Joneses sit. So when things change and the rules don't apply, we get uncomfortable. So in the case of transitions, so let's use the new boss scenario. The old rules in our case, so the John Felton rules, whatever those were, I don't know those, that's the language here. How do I do things? They don't apply. I'll give you a real life example. I'm a big fan of MBWA, which is actually a thing. You can look it up. It stands for Management by Wandering Around. I have always been a person who likes to go out to where people work. My background is clinical. I used to work as a therapist in physical rehabilitation, mainly strokes and brain injuries and spinal cord injuries. My touchstone is patients and the people who care for patients. So when I came to work here, I did that. I wandered around. I'd walk through the clinic, I'd walk through the immunization space, whatever we had going on, I would walk through there. For a while, people were really nervous about that. What's he doing here? Why is he here? Is something wrong? They quickly learned that was just I just went out there to talk to people and to kind of get that personal refresh of being where what my touchstone is. Part of the reason that I do that is I like to get to know the people who work. There's a lot of value in being, in saying to someone, I heard you became a grandma, or I'm really sorry, I heard that your aunt died, or whatever it is. That old saying about nobody cares how much you know until they know how much you care is true. And that's, in my world, that's NBWA. That was different here. Lil was not a person who did that. Doesn't mean that my way was right and hers was wrong. It's just different. So there's a new set of rules when I arrive because I show up in clinical spaces and where people do work. That and for some people, creates fear. Other people say this, hey, if we got someone from leadership here, I'm going to tell my story. I'm going to ask questions. They see that as creativity. But because of the uncertainty, old rules don't apply. We don't know what the new rules are yet. Because of that uncertainty, people feel anxious. Most people feel anxious. A few people see creativity. I'm a person that loves the neutral zone. I'm not a big fan of doing the same thing over and over. I like a lot of variety. When I was recruited for the CEO job at the Northern Rockies Cancer Center, I went through a full day in Kansas City with the recruitment firm, taking all these personality tests and all that stuff. They come out with this big report, which ultimately says, give him a lot of variety, he gets bored easily. I could have told him that. But that's just me. I like uncertainty. I like periods where there's no rules. Most people don't. You just have to recognize that. For most people, it's the fear and that they recognize rather than the creativity. So look, one way analogy I use for this is being in the neutral zone is like being a blind guy on a cliff. There's an edge out there somewhere, but the only way you find the edge is you fall off it. Go back to the idea of rules. Rules create the box within which we work. So the rules are the fence. If you take away the rules, I don't run into the fence before I fall off the cliff. I discover the edge when I fall off the cliff. So what are your choices if you're in that uncertain situation, if you're in the neutral zone? One choice is to walk around and recognize that there's some chance that at some point I'm going to fall off of this. I'm going to fall off. I'm going to go too far. I'm going to go someplace that is not allowed. If you do that, you take that chance, right? Now, the beauty of that is you may discover some spaces that you haven't wandered in recently, right? You may discover new things, new opportunities, new ways of doing things. There's no rules that stop you from doing that. One element of rules is because they set the limits, they tell you what you can do, what you can't do. If there's no rules, you don't know what you can't do, right? So you have a lot more flexibility, a lot more creativity. The other choice, if you're the blind guy in the cliff, the safe choice is to sit down, right? I know that I'm standing on solid ground right now. If I sit here and don't move, I won't fall off the cliff. It's the safe choice. It's also the choice that nothing comes out of, right? Because as long as I stay in the same spot, I'm safe, but I can't do anything. I've made my decision that I'm going to hunker down and wait it out. Those are kind of the extremes of what people do in periods of neutral zone transition. Let's go back again to our situation here. I still do management by wandering around, even though I don't manage anybody, just because it's my touchstone. It's what I like. It's a way of doing work that's rewarding to me. There are people who have said, I'm surprised to see you out here. They're surprised because they relate that behavior with being a CEO. Others are, they're glad to see me because we've built personal relationships. So there's all kinds of reactions that you get from people. But the key thing to understand as a leader, and in particular when we're talking succession, is this neutral zone is uncomfortable for most people. Now, I told you our story here is the 3 years of notice. There was no way that I was not going to tell our staff that I had set my retirement date, because go back to change, right? If they don't understand the why, then things look random and scary. So if we start all of a sudden hearing, that the board is interviewing search firms for the CEO, and they don't know that I'm retiring, what do they assume? Well, is he leaving tomorrow? What's going on? So I was very upfront and said, I'm leaving at the end of 23. We're gonna, the boards are gonna engage a search firm. That search firm will find candidates, they'll interview, et cetera, et cetera. Being transparent in that way starts the neutral zone. Now they don't know what's going on in terms of what do we expect. That they go through, they start this process of transitioning, like you've been here for a long time, we're going to miss you, or thank goodness you're leaving, but we still understand you, whatever it is. It starts the clock. So we make it through that first process of going from John Felton is our CEO to the end of that stage is we have a new CEO started January 3rd, 2023. Now we have a new neutral zone to go into, because now there's both of us here. I've been really clear that I'm not the CEO, but there's a comfort level for some people with that. So we have to work through that transition. That's where we are now. There's this kind of neutral zone uncertainty because my rules don't matter anymore. And again, think of rules as the way you do work. It's the boundaries that you work within. Nobody knows John's yet, John Forte. They don't know his yet. So we're in the neutral zone. And then the third stage you work that is called new beginning. And that's where you have a new reality. In our case, John Forte will be well established as the CEO. He'll do things his way. Will he do MBWA? I don't know. Maybe yes, maybe no, but he'll do it his way. One of the things we've had here for a long time is Tuesday morning senior staff meeting. Been here since I started in 2004. When Lil was here, that ran one particular way. When Lil left and I ran it, it ran a different way. Now it's John's meeting and it's running a different way. So you have these little mini transitions going on even as you work into new beginnings. New rules, the new fence around our work come into place. They fit that new reality. So my rules, and again, use the term rules sort of broadly, so again, the structure of how we do things. The John Felton CEO rules don't matter. They're gone. I'm not the CEO anymore. The John Forte rules are developing, and at some point will be in place, and those will fit the reality of his leadership. You can tell when you start to move into this because you begin to lose some language. You stop talking about, well, we used to do this, or in the old days. The biggest one is using new as a modifier. So when John Forte is no longer the new CEO, but the CEO, we're into that final stage of new beginnings. We built, in the time that I've been here, we've built a number of different facilities on our campus. The most recent one we built was a new community health center. That is no longer the new clinic. It's just the clinic. A lot of people don't even know that there was an old clinic, right? Because they came to work here and they saw that beautiful new building and said, this is where I go to work. So this is the clinic. When you restructure, and we've gone through some leadership transition here as people have retired. So we no longer have a new public health VP. We have Eric, who's our public health VP. Bob Janicek is no longer our new chief information officer. He's our CIO. So when you start or stop using the word new and stop talking about kind of harking back to the old days, that's when you're coming into this stage of new beginnings, when you have a new reality and your organization has just moved to its next iteration. So here's some really key things to understand about this model. One is, this is not a linear process. You can move back and forth. You can occupy multiple stages at the same time. So when I was going through grad school, both in my business administration program and my public health program, how many times did I hear about Maslow's hierarchy? Let me tell you, I don't like Maslow's hierarchy. That's just me. The reason I don't like it is it's too simplistic. Because if you think about that model, and you've all been through this, when you satisfy your needs at that lowest level, then you address your needs at the next level. And when you satisfy those needs, you address the next level. You can go backwards, but you can't, the model is you can only focus on one set of needs at a time. People aren't like that. People are complex. We can worry about multiple levels at the same time. But if you're a hardcore Maslow person, you say, well, nope, you can't do that. This model says you sure can. And you can move forward and backwards a lot. So there are people who, as they begin to work through that neutral zone and they begin to get some sense of, I understand the new way things are going. I'm moving forward to new beginnings. Then something happens and they fall back. I'll tell you what it's going to be in our organization. I'm predicting this already. We've got in the next 9 months, there's going to be 3 long-term senior leaders that are going to retire. So I'm actually the 3rd one. Our chief financial officer, who's been here for 15 years, is retiring at the end of June. So when Shelley retires, for some people, there's going to be this hearkening back to, oh my gosh, we've lost, all these leaders that we know and we've liked and we understand, and they're going to fall back into that sense of grief again. Then they're going to have to work through, okay, now we have a new CFO. What does that mean? What does that mean for how I report my financial things, etc. Then we're going to get to October, and Judy Stewart, who has been here, she's actually retiring on her 36th anniversary, and she's done everything in our organization. Her primary leadership portfolio right now revolves around performance excellence and organizational culture. Judy's going to retire, and it's going to be, oh gosh, all things we put in place while Judy was here in terms of our culture. What's going to happen with that? People are going to fall back and they're going to realize, oh gosh, now Judy's gone and Shelley's gone, and pretty soon John's going to leave, and we're going to go back to that grieving the what we understood, and then we're going to go through it again. And then at the end of December, I'm going to retire, and again, doesn't matter whether people like me or not. Now it's going to be, I know John Forte's been here for a year and he's been the CEO, but John Felton was always here, and maybe he did stuff or he didn't, and now then they're going to have to go back and go through it again. So there is a lot of movement back and forth, and a lot of things can trigger this. In our community, we've got St. Vincent Healthcare, the Sister Charity Hospital's been here for more than 100 years, is now part of the Intermountain system. So there's a lot of transition going on at there. Billings Clinic, the other big hospital system, is in merger talks with Logan Health out of the Flathead. Same thing. So this is just a constant. We've actually gotten a lot of employees who have come to us from those 2 hospitals. And why did they come? Because they didn't like the sense of uncertainty. So transitions really do affect people. The other thing to recognize is people go through these stages at different speeds. It's highly individualized. Some people really struggle with the grieving element, the loss of something they understood. This is not something you can do by policy, so you can't write a policy that says, I understand that we're going through transitions. For the next 30 days, we will be in letting go. We will then experience a 45-day period of neutral zone, after which we will move into new transitions or new beginnings, and it'll be over. Thanks very much. Everyone's going to do this at their own pace. Some people really struggle giving up. They really struggle with that sense of, I'm losing something I understood. I'm losing what I knew. If these people have power or authority, they can sabotage the change initiative. This is why it's all about leadership. Leadership has to help people work through this. If you have a leader who can't make the change, then they need to go. So I'll give you a real life story about this. When we made the decision, we meaning the Board of Health, to go through rebranding and look at a new name, there were some people in our organization who really struggled with, what if the words health department are not in the name? Are we still going to be a public health agency? And the day before, the board was going to meet and have this conversation about, the rebranding and are we going to adopt a new name. We had a meeting with our senior staff because I knew there were some in that group who were really struggling. And what I said to them was, it is our job to execute the directives from our governing body. That's what we do. We're staff, we're not governing. If there's any of us who, we don't know what's going to come out of this 2-day retreat with the board. They may say we're going to still be Yellowstone City County Health Department. They may say we're going to keep the word health department in there somewhere. They may pick something entirely different. We don't know. It's still our job to execute their governance directive. If there's any of us who cannot do that, then we have a moral obligation to resign, because we as leaders have the ability to sabotage the decision that the governing body is about to make. There was one person in particular who really, really struggled with not having the words health department in the name. In the end, the decision from the board was, we are not going to use that name. We're going to use something different. Ultimately, that name became Riverstone Health. That retreat was on a Friday and a Saturday. And on Monday, that individual, when I came in, there was a letter of resignation from that person. I think that was the right thing to do. That individual just could not get on board with the direction that the governing body was taking. And they said, I can't do this, and resigned. It was the right thing to do. There were other people in the organization who had the same concerns, but they weren't in leadership roles. They couldn't sabotage where we were going. They could slow it down. They could subtly sabotage, but they couldn't do something from the level of a leader. A few things about leadership considerations as we look at this. One thing is just understand the model and the 3 steps, and appreciate the individuality of how people are going to respond. Again, you can't force someone to move faster. If people really can't move on, if they can't get out of that grieving response, then the best thing you can do for them in some cases is just say, like, you're not happy here. I think you should think about going somewhere where you can be successful and happy. We should encourage people to talk about their concerns, their fears, what they're losing. If we build good relationships with people and they're willing to talk to us, you can help a lot of people work through their concerns. So encourage them to talk about it. To say, and part of that is sharing your own concerns. One of the things that I've done is I've talked to people about the idea that we had talked earlier about. I will need to disengage as I get closer to retirement. I'm not a person that can go full speed till 5 o'clock on December 29th, 2023, and then be done. I'm not going to retire in place. I'm not going to just sit here and take up space. But when we get closer, there'll be a part of me that's going to need to back out. And I just think if we're open about those things, it helps people work through their concerns. Really important is don't disparage the old ways. Even if, if you're bringing in a new, say a new health officer, director of your health department, and you really dislike the old person, the previous one, don't disparage that person. I'm one of those people. I'm a self-described pathological optimist. I think people generally do things for trying to do good. And if you disparage that, then you're really impugning someone's motives. So let me tell you a story about this. When we went through our branding initiative, that ended up ultimately with launching the Riverstone Health brand in 2008, we used a branding company or consulting firm out of Bozeman. I love these people. We still work with them. I think this is their impact on our organization is you couldn't even begin to quantify it. I think they did a marvelous job. There was one thing that happened that they dropped the ball on, though. And this might seem a little silly, but when you hear the whole story, I think it'll start to make sense. So we were in a room, we were talking about how do we really encourage this sense of entrepreneurship and creativity, and that is not a natural way of doing things for a lot of governmental entities, right? We always hear about the stodgy bureaucracy and all that kind of thing. Now, as I mentioned, in our structure, our interlocal agreement creates an entity, but we are still the government. We're still a public entity. We're subject to all public meeting, public records, laws, all that sort of stuff. So we are the government. People used to say that when we created that structure, it was quasi-governmental. And my response to that was, that's like being quasi-pregnant. It's binary. You're government or you're private. You're pregnant or you're not. So we are the government. But what our consultant was talking about is how do we position ourselves as being entrepreneurial and not stodgy governmental? And he said, and just look around this room. You know, the color on this wall just screams government. Now that seems like a fairly innocuous comment. Here's what he didn't know. Underneath that, what he thought was stodgy governmental paint was a horrible color. That building was built in the mid-90s. That salmony, corally color was really popular. It was terrible. Lil, who was the CEO at the time, spent a lot of political capital and a lot of money to repaint that building. And painting it into a more of a neutral, arguably governmental looking color was a really big deal. And people who were here were ecstatic about not having the salmony, corally building. When our consultant made that comment, what he didn't know was there was a really good reason why that wall was that color. And he hurt feelings, not intentionally, not maliciously, not even knowingly. But if we disparage the old ways, what we're really doing is we're telling people they're dumb, and we don't want to do that. It's really important that you focus as a leader on why are we doing this? Go back to the why. This is important to us because keep your eye on that prize. Don't be binary about, yeah, we're done. You know, along the way, we're gonna do these things. We're gonna celebrate some progress. In our search process here, which took almost 2 years, we kept the staff really informed about, okay, we start off with, you know, we had 125 applicants to the search firm. They narrowed them down. Now we're at 30. We interviewed 10, you know, that kind of thing, just so that you can say we're making progress. If you have a really complex transition going on, you can create these ad hoc teams that are thought leaders that really help facilitate the transition and provide feedback to management. What are people concerned about? What are they worried about? And use that until the process is complete. And that's it. I think if we look at transition more as an emotional response to the change rather than just like, why is everyone so upset? You know, we got a new boss. Everyone gets a new boss eventually. And recognize those emotional aspects, we really can get a lot more out and have a much more successful change process than we might otherwise. So with that, my 45 minutes took 46. So there we go. I think we're good. Thank you.
That was good timing. I always like to add, and I think you touched on this a little bit with the emotional piece, is that we talk a lot about people retiring, but we went through an unexpected succession, if you will, when we had a coworker who unexpectedly died a year and a half ago. And besides it being a different, you know, grieving on top of grieving, that sudden, like, did we have a plan in place? Where were all of those files saved? You know, how do we suddenly navigate that person gone? And same if someone were just to quit and up and leave. So just always keeping that in mind is it's nice if you know someone's retiring and you go through all these changes, but to consider if it's very unexpected as well. And this managing change information, I find really important and useful. Does anyone else have any comments or questions for John Felton's piece?
Did you find any of these strategies helpful as it relates to dealing with the public or the community as a whole? And I don't know if Yellowstone County is a large community, but I am listening and I am relating it to our small community and the big change that we went through as just a county-owned but not operated department to a county-owned and operated department.
Yeah, I think anything that people perceive as a change in their world creates this transition response. And the more that we can explain to people the why, the easier that transition becomes. If your situation was, you know, and where are you, Stephanie?
Carter County, and we can't really undo the why. It's more like picking up the pieces from the why.
Then if you can't get to that point, what you can help people understand is this is where what we see some benefits. This is what we hope to accomplish. You know, I know in Carbon County for a long time, the public health was contracted out to Beartooth Hospital, and then that changed. And if people don't understand that there's some benefit and some reason for doing this, it may be as simple as it saves us money, which to the taxpayers is a big deal. It may be that we feel like we can expand our services, we feel like we can be more effective. There are people who struggle so much with change and transition that even things that are really positive for them, they get really hung in that grief reaction. Because I understood it. I knew why we did. I knew what that meant. But I think the importance of being consistent with people and telling them, you know, we're doing this for a reason. That's, you know, we're gonna make some changes. If you can also share the impacts of that. So, you know, what happened as a result of this, and help them realize that we made some progress. But I think transparency is really important. There's a risk to transparency. You know, I will tell you a simple story from our organization. We went through a gigantic process of reclassifying and repricing jobs. And we made the decision very intentionally that we were going to put the entire new salary matrix on our intranet site, knowing that there would be people that said, well, wait a minute, you know, I know what Susie does, and I know that I do more than that. So why does Susie make more money than me? It would have been the short-term easy thing would have been to not put that out there. It's like, hey, good news, you're getting a 7% increase in the way your job is being classified. But if people don't have information, they fill in the blanks. Just like nature abhors a vacuum, brains abhor absence of information, and we fill it in. And when we do that, people are more creative than reality. So their stories are probably better than anything that is true. So I'm a big believer in just telling the truth and recognizing that there is a price to pay for that somehow.
Thank you again, John. So now we're at the top of the hour again. So I would suggest a 1 to 2 minute super fast break to pee or go to the bathroom or refill the coffee. I'm slowly refilling mine. I don't know if anyone's noticed. If I keep getting up and leaving, it's just more coffee. And then we're going to come back and we've got Lydia Check who hopped on, and she is our wellness director at the center. And she's going to lead us through a wellness activity to keep our brains limber for the next half of this training. So take like 2 minutes max to run and go to the bathroom, and then come back and we'll do a wellness activity.
So as people are returning, I will just give a brief explanation as to what we're going to be doing. We're going to do a little combo stretch session and then a brief mindfulness. And just so I keep an eye on time, when would be ideal for us to?
I think we have 10 minutes earmarked, and then I think we can do a full 10.
And so once we stretch and move our bodies a little bit, we will do a brief mindfulness session to some chimes and some Himalayan singing bowls. If you have the opportunity to put on headphones, I highly recommend using headphones for the best listening experience, just because you will be able to hear the stereo audio. However, it's not required. All right, so we're gonna get started first by just moving our bodies. Let's go ahead and stand up for a moment. And if you want to be on camera, that is awesome. If you would prefer not to, that's okay too. So we're going to just move through the body, doing some stretches side to side. You can pull on this arm if that feels good for a little bit more of a stretch. And there's no wrong way here, so just moving through whatever feels good. I got my back to pop, that felt good. Definitely opening up the shoulders, stretching across the side. We can do the same coming down behind the back, just loosening up those areas that get tense from sitting at a desk. Then just matching the other side. And if you have the space for it and you would like to, you can go into a forward fold. If you need to keep a bend in the knee, you can. Otherwise, you can get a little bit straighter in the leg and feel that stretch down the hamstrings. Coming up slowly, maybe in a little bit of an arch towards the back, just supporting by tightening the abs as we lean back a little bit. If you want, you can put your hand on your desk or your chair, grab the foot behind, and do a little bit of a quad stretch. Those quads get short from sitting. And then switch to the other side, taking a couple deep breaths. Oh, we get puppies involved, yay. The best wellness break. And then just kind of shake things out. If there's any stretches that feel good for you that you want to do, you're more than welcome. There is no right or wrong way. This is your break, and the only thing that matters is your comfort. Once we're seated, we're gonna just check in with our body, see how we're feeling, settle in a comfortable way. And on our next session, we're going to take a deep breath into the low belly, feeling that diaphragm expand. And then exhale through the mouth, letting out a sigh. Again, in through the nose, deep into the low belly. Letting out a sigh. If it feels good for you, on an exhale, you can drop the chin to chest. Noticing a stretch in the back of the neck, dropping the shoulders down. And on an inhale, gently rolling to one side, feeling the stretch on the side of our neck. On an exhale, rolling back down center. On the next inhale, rolling to the opposite side. Feeling the stretch. Taking a deep breath, and on an exhale, rolling back down center. And on an inhale, lifting the chin and finding the back of your seat and just allowing yourself to melt into your chair. You can turn off your camera and lean back, totally surrendering to this moment. And just noticing your breath. Mindfulness is the awareness that arises when we pay attention in the present moment on purpose, without judgment. just noticing the breath as you inhale and allowing that curiosity to draw your attention towards your breath. With each inhale, we experience a new opportunity to focus in the moment on our breath. And with each exhale, we feel our body soften, release, and let go a little bit more with each exhale. Knowing it's not about clearing the mind, but instead just observing what's going on in the mind, noticing when our thoughts fluctuate, and bringing our focus back to our breath with each inhale. Inhaling, we focus, and exhaling, we relax. On your next inhale, bringing your attention up to your brow and eye area. And on the exhale, feeling your brow and eye area release, relax, and let go. Feeling all the muscles in our face begin to melt as we inhale and bring our focus to our jaw. And on the exhale, feeling the jaw release, relax, and hang loose, finding space between the teeth. Inhaling, bringing that relaxation down into the neck and shoulders. Into the arms, hands, fingers. Into the chest, shoulders, belly, hips, legs, feet, and toes. Inhaling, taking in a deep breath that revitalizes us head to toe, and exhaling, letting go of anything that is no longer serving us. Taking a moment to think of something that you are grateful for And inhaling, reflecting that gratitude back toward yourself, thanking yourself for engaging in this educational experience, thanking yourself for your hard work, and for engaging in self-care today. As we slowly come back, allowing the chime to bring us back into the room, inhaling through the nose and letting out a sigh. Beginning to slowly wiggle fingers and toes, stretching through the arms and the legs, blinking open the eyes. Noticing the things around you as you come back into the room, and taking your time as you slowly come back again. Turning on your camera when you're ready, as we prepare for our next piece of the training. All right, thank you all for inviting me here to facilitate a wellness break. I hope that it left you feeling refreshed and ready to absorb the knowledge coming your way.
Thank you, Lydia.
Thank you, it was a pleasure.
I love having her on the team. Everyone's always a little bit more relaxed. So now we wanted to make sure you had a break because we threw a bunch of information at you. And now we would like to just allow some discussion. And sometimes it can be tricky. There's not a ton of us, but even in, it's easier in a little smaller space. So I've put together just 2 breakout rooms and assigned 2 of our panelists to each one. So you guys can chat with our experts and our experienced folks here and ask any questions on what's been presented so far with transition and change and the experiences that the 4 of them shared earlier. So that's what we'll do next for about 15 minutes. Does that sound good, Des? Am I on track?
You're on track. Thank you.
All right. Well, I'm gonna hit the button and you'll see an invite to a room. So please head in there. It will automatically kick you back. And if you have any needs, you can holler at us in the main room as well. So I will open those up now that we're nice and relaxed. Were there any particularly good topics or questions that came up in the rooms that the panelists would like to share?
I will say we had some really good discussions around the topic of transparency.
Awesome.
And kind of that struggle with at what point are you transparent versus at what point is there so much uncertainty that you're making people nervous or, you know, kind of like almost adding to the stories that are told and trying to also find our way as leaders of sharing why we made decisions, but not justifying from the fact of trying to get everybody on our side and to agree with us and what is that balance. And we didn't nail it. We just talked about that that's an ongoing piece and that it can be lonely to be in these positions.
For sure.
And we had in our group, Brian, we had a lot of good discussion. We have 2 people in our group that are planning retirement after very long careers and a lot of leadership in the state. But then right toward the end, Brian, who I hope isn't retiring, but yet, proposed to add a step to John Felton's phases that he had presented. And that step, it was to celebrate, you know, even if somebody's not leaving, celebrate what we just accomplished, what we've just been through. And I thought that was a really neat idea. There was a little more discussion about how to do that.
Oh, I like that. I think that's an important step for sure. Thank you, Brian. Thanks for sharing that. Any other particularly awesome things that came out of discussion? All righty. Well, I will turn it over to Ellen, who will take us into our next section on the culture of politics.
All right. Well, I'm not sure of what is a good transition type statement from what we learned from John, which I thought was so excellently presented with great stories, so we could have some humor. But I think there is one, and just in our breakout session, I think one of John's major messages that I got was that it's not the change, it's the transition and the reaction to it. And I think that might give me a thread to transition to this next topic, and that is it's not just where we're at right now in public health, or where our community is, or our society, or our legislature, or whatever. It's how we respond to it, and also how not only how it impacts us, but how we can try to influence it. And what I experienced early in my career, probably because my original education wasn't public health, it was community, but more from a community public health nurse perspective in the master's program. I had come out of intensive care early in my career. And, if a person, we did not have clients that could even breathe on their own. So the idea that a patient or a client would, start talking with you, let alone arguing with you, I mean, it was just, it didn't happen. And so, we worked a lot with the technology and the science and so on and so forth, and really were shielded from, I think, the human part of it. The other part of it. And so for me, moving into public health, even though I, had that education on community work and blah, 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 and all the didactic, to discover that science was not going to carry the day just about blew me away more than once. And what I came to really love about public health, even though I sometimes love it with a sense of Black humor, is the culture and the politics of it. And I don't say that in a negative way. And actually my talk is culture and politics. I'm not sure that conjunction matters much. One feeds the other. And so rather than get didactic in any way here, I have no theory or model to present to you. One of the things that really helped me, and I hope by sharing this may help you, is yes, we have been through a very big and disruptive time in public health, and we are still emerging from that. And from what I'm seeing, people are taking great advantage of the opportunities to change, but there's some changes we're not even sure what they mean to us. And we always have had a certain culture to public health. The culture of public health in Montana is different than the culture of public health in a different state. It's different county by county. And at first that can seem strange and odd, but then you can get very endeared to it. But what I'm inviting you to do by this is come on in, let's jump in and just immerse ourselves in that culture and just talk about it and experience. And then maybe we won't feel so all alone, or feel like we're in a place we've never ever been before, that somehow, some of the major changes, particularly the legal ones, are somehow the end of the world. They're difficult, and I don't have to carry on forward through them. But for those of you that are newer, some of these changes are going to be the way that it always was for you. And so you will, as you develop your leadership and as you leave behind, as you retire or depart, the the people that are staying will find their own way, and that's what leadership is. So one of the things that really helped me when I was going through that culture change long ago was to understand the history of public health. And I don't think we in the country look at history enough. We certainly don't seem to learn from it. There's a lot of sayings about that. And I actually thought twice about, should I bring this topic to this forum? And I decided to, one, because it was so important for me, so I hope it has worth for you. But also, I was just recently listening to a presentation from a Native American man at the Pine Ridge Reservation. And he was talking about leadership and planning for their community. And he said, when we plan, we go 3 generations back in our history, at least 3 generations back, 3 generations forward, and then we plan in that middle, so 7 generations. And I thought, yeah, we can't really know where we are if we don't know something about our history. So, whoops, this is not changing.
If you hover your mouse over it, there should appear very faintly in the lower left. If you see over there, there's little arrows.
There it is. Yes, it did. I'm gonna skip this one. I don't want to go off on that tangent. So what we're going to do is we're just going to talk about the nature of public health and just kind of immerse ourselves as if we were swimming in, come on in the water spine, and realize that it has its own essence. And that is changing all the time, whether we can put that forward in a didactic way or not. But, you know, there's a lot of that politics and culture and some of that tension and that constant change that we feel that I think was just magnified and catalyzed during COVID, but really it's always been there. And it's built right in, it's inherent to what we do. So if you look at just one of the many mission statements for public health, and this is, you know, this is kind of an old one, but it's still out there, is the mission statement of public health is fulfilling society's interest in assuring that conditions in which people can be healthy. Well, that builds in what I think is a big portion of culture right away and a big portion of politics. The word science isn't even in there. And it says society's interest. So it's inserting society in a big way. And it's assuming that society has an interest in public health, which I think over our careers, we've all had opportunity to question or to what that question is. But it also brings us a lot of planned and unplanned opportunities to get through change. So the fact that we are working with society as closely as we are, I believe, and I view public health as working at the intersection of science and society. So if we want to take our science and say, well, this is what immunizations do, we can march right on through that intersection and we will not be experiencing public health. Or we can do as some members of our communities do, is say, well, this is my value system and this is a free society. And what we really need to do is live at that intersection. And that can be a pretty tense intersection to live at, but it's inherent to public health that we live at the intersection of science and society. So the frustrations that come with it and all the things that come with it, and they're really built into public health. And that is the essence and the nature of that is the environment in which we are making change beyond the change we try to make in our organization or change is happening to us. And I think it's even more difficult there's more opportunities for collisions in that intersection in a free society because our rights to liberty are so incredibly strong and valued and actually committed to constitutions. So let's just look at that intersection of science and society and I know these aren't new to you, but I just want us to jump in that water and kind of feel it and know that it's okay to swim there, that that's what we do. So we have inherent tensions between the fact that we're doing public health, but to do public health, we're focusing on things that are private to the point of intimate, people's health. And that creates an opportunity for tension. Now that tension can be a conflict, but that tension is also necessary. And I think John said this in several ways, that you have to have tension for change. You have to have an unfreezing, or you have to have forces, and then they finally resolve. And so what we're trying to do is we're trying to use that tension, which means we have to live with it. We have to sustain it, and then try not to have it just blow up and have it resolve. And that's a very hard thing to do. And I think COVID just took that dynamic and it just exacerbated it so that, you know, we could see it, and it, you know, the chips fell all over the place. Culture, it was hard for me to learn early on, and it sometimes still is. And in COVID, I felt like I had learned it. Now I had to learn it again. But I really believe that people make their risk choices based on culture. I think if you're a football player, you're making a different, you're not making a scientific risk choice. If you're trying to run a business and you don't want to close it, if you're sick and you're really afraid of something like COVID, or if you don't have a lot of money and some sort of change is being made on you, that is what influences people's sense of risk. And it's their sense of risk that's going to cause them to try to work with you or not work with you, or to, you know, move the needle in a certain direction. We're also dealing with the fact that we're trying to call attention, particularly as we focus more on inequity, to members of our society that may have really not easy to talk about situations. And at the one hand, we're trying to call attention to them. These people need help, and, you know, everyone, no one should be left behind. But how do you do that without stigmatizing? That is really hard. And as a leader, and just as a practitioner, you have to ask yourself, when you go public in a big way, every time you do that, you have to say, am I speaking in a way as a leader that is calling attention, but finding that sweet spot between attention and stigmatizing? I think that's very difficult, and it takes a lot of practice and leadership skills to do it. It's easy for us to talk about, you know, we're going to save money if we invest in public health, but in our society, it's going to come back and say, well, it's not a problem. We don't have to invest in it because it's not a problem. And then, of course, the very infrastructure that kept it from being a problem gets ripped away, as I believe some of it has in the recent legislature, and not just in Montana. And then we take in here in Montana, where that explicit right to privacy is in the Constitution in a way that it's not in the US Constitution. And that explicit right for the public to participate, not just witness, but to participate local government in what goes on in their government, adds a whole new and more extreme level of that tension. So as a leader, it's hard. It's hard to turn that tension into something good that can bring about change and resolution, but I do think that that is very much the water we're swimming in, and I think that's the challenge. And I want to look at history enough, even because it's kind of fun, but to point out some of those tensions, good or bad, and how they resolve, have always been in public health, always been in public health. And they're there now. And so the upheaval we're feeling is, you know, a higher magnitude, I think, during COVID of those tensions. And then the legislative aftermath. And I'm not trying to say the pendulum just is going to swing back and forth. I'm not trying to say that. I believe in the spiral theory of change. As it looks like we've been here before, but I think we're a level higher than we were. I try to believe in that. But those tensions have always been here. And this is a rendering of a woman by the name of Mary Mallon back in New York City. And she's trying to stab the gentleman on the left with a fork. There were times during COVID that the tension did feel that personal and it did feel that threatening. But I think we can say And we have to live through that. I think we can see that this is not the first time, even though it's a piece of art. The woman on the right is, or the person on the left was actually an epidemiologist for the New York City Board of Health, and his name was George Soper. The woman on the right, whose name is Mary Mallon, is actually known as Typhoid Mary. And it was his, by God, I'm not going to give up. This woman's not making anybody else sick. And she did try to attack him with a fork. She did escape from him. And of course, there's her side of the story. And her side of the story is, you're taking away my livelihood. I'm not sick, and you can't tell me I can't work. Does that sound familiar? We've been here before. Another tension is, I think, really plays itself out in the vaccination. And I'm sick at heart right now, but I know you are and will carry on and have, because the anti-vaccination movement is just a good example of what's good for me privately, should be completely my decision. And what's good for the community, I don't have to have, as a person, any bearing on that. This drawing comes from the very, very, very early 1800s. It's not recent, it's contemporary from the times. And it's called The Cowpox, or the Wonderful Effects of the New Inoculation. And it was published by the Anti-Vaccine Society, if you can read the bottom. And if you look at these people that are being inoculated, apparently they're being compelled to be inoculated. What they're afraid of is, if you can see, all these, they knew that they're being inoculated with pus from cows' udders, basically. I mean, think of it. And what you can see is little bovine things are growing out of their heads. They're just really scared of this, see? So you can say, well, we should have come further than that. And then you can see that the falling back on vaccinations is not just that fear, it's that liberty. You can't tell me what to do. I have an individual right to freedom. And that's going to change as your culture changes. And right now, my opinion, our culture in the United States, besides being reactionary to COVID and all the compulsory things that happen, it's very divided. I mean, whatever you think of that division, everyone who speaks of it talks about that division. And so these kinds of things really break out in that division. And that has changed our laws recently. The other inherent tension that we have, I touched on earlier, is we're always trying to sell prevention. It's cheaper, it's $1 saves 10, blah, blah, blah. But that requires not only the sense that you're working and what you do as an individual, how you exercise your liberties or restrain yourself affects the whole community. It's that somebody's going to invest in upfront. So we're talking about whose money is going to pay and when. And with investment up front, it's very, very hard to get money on the table, because the counterfactual problem is not manifest. They don't see it. And I just love this poster. This is also contemporary. Do we have some kind of scary posters today, maybe about vaping or not wearing seatbelts or not eating vegetables? I mean, these things, this part of our culture has always been with us. My favorite part of this poster is, if you can read it, the flies that you see in your privy will soon be on your dining room table. A little bit of scare stuff there. So that's not a new tension for us. I think the one that really, really reared its head and actually has made some of the biggest changes to our local public health system, politics, came out of that culture of who's in charge and who can tell me what to do and who can tell me what to do when it's something that's going to hurt me and I don't really want to do. And that has historical roots as well. in order to even have the public health system that we have in the US today, even though it is changing and rapidly changing, and in some ways changing back, which was scary. But as John said on our breakout session, you know, we get through winter and we get through summer, and then we get through winter and we get through summer. So I think we will get through this. But what it took to create what we know as local and state public health was a whole lot of dead people and a whole lot of disruption in the largest city in the country. And it was 3 waves of cholera into New York City. And they were devastated by the first wave. And they knew it was coming in the second wave because it would start in Europe. And so they knew it was coming the next year. And they were devastated by the second wave. And what they learned was we have to put prevention in place now. Excuse me, this has to go off. We have to put prevention in place now while we're not in the middle of an epidemic so we can use it. But people wanted elected officials to be telling them what to do. And so the question of who got to tell them what to do came up. And the mayor at the time said, I know it's coming, but we're not going to have an unelected health board tell us what to do. I'm the mayor. And we are starting to see some regression back toward that in about 26 states, Montana being one of them. Locally, what I want to focus on is how public health was manifest in Montana. Public health in Montana is a decentralized system. So it's one very much of local control. And when we didn't have a state health board or any sort of state authority or even a health department, we had a land board way back. The cities that developed, with Butte being the first, basically took that eastern, like what was developed in New York City, and they brought it, that whole machinery, and developed local public health boards. And as the trains came in, each city that developed local public health boards at the local level. The people in charge of those cities got tired of being the ones to exercise quarantine and isolation when every other city wasn't doing anything but sending their contagious people on into their town by train. So in 1901, a state health board was established. This was a petition from the mayors and the county commissioners. And it was also required that not only would there be a state health board, but that every single county was required to have a health board. And that's how we got our start. So we are a very decentralized system. And as someone who does site visits for FAB, I only get sent to decentralized states because I don't have familiarity with states that are run top down with districts. Well, what does that mean? So we have 56 different counties and 8 tribes and some multi-county districts, all doing things differently. So when the legislature created House Bill 121 and passed it, they said that your local health board, whatever it looks like, is not going to be the final word on adopting rules. And that is brand new. That took like 120 years of history. Well, that might be okay. I can't say that it is, because there's a provision for county boards. There's a provision for multi-district boards, as we see in central and eastern Montana. And there's a provision for city-county boards. So while most of our counties and all of our tribes actually have a county health board that the commissioners are the elected officials on, or they have to put at least 2 other people on the board, or they can appoint the whole board. As John talked about, most our larger city-county areas, that was a newer configuration for boards. So while they are the minority in terms of what type of local authority was out there, they have responsibility for the public health of the majority of the population. So when House Bill 121 went in, it did not consider what that would do to those city county entities. And I'm sure it made changes in many of the county ones too. It's not a clearly worded law. And that changed many years of cities and counties working together through their health board, appointing their health board and knowing who was making the rules. And it opened it up for what is still widespread confusion. And in fact, I just wanted to point out where our tribes are. Let me back up. In spite of that, those differences, so John's was set up differently, but he still had a health board. And I could still look at Title 50, and I knew that his health board had the same powers under the statute as my health board. And even if Flathead and up where Hillary was did it differently, I knew we had the same powers. There was something about that local control. And we're also a home rule state, which in the shortest way to say it is home rule recognizes and sanctions and puts in place local control. It's actually a legislative type of control. So when they changed that, it broke up a lot of that local control. It broke up those partnerships. That would have been enough change. That would have been enough. I was literally keening over it. But those of you that are newer, it's going to be your always environment. So you'll lead us through. I know you will. But worse than that, I think, is it created so much confusion. And so we have a culture of kind of reeling from what has happened, right? We want to keep in mind that it didn't just happen to public health. That division that we see across our nation is affecting, right now, this year's legislature is removing things that were home rule that have to do with planning and how houses do or don't get built. And I mean, it's not just happening to us. I'm not sure that makes you feel better for me to say it's bigger than us, because it's kind of scary. But home rule is definitely, we are losing a lot of home rule in the state. We're feeling it in public health, but we're not alone. The decentralized health system, I think I covered all this, so I'll just move on. So just a year ago, almost a year to a day, this nice article, which you haven't read it, go back. And it's a really nice write-up about what House Bill 121 did. And the title calls it Rolled Back Public Health Powers, which it is for the board. It leaves some areas in limbo. Well, I checked with Matt Kelly, because I'm, not working anymore. And I said, how's it look a year later? Because all these interlocal agreements that John did such a nice job setting up how his is different and ours was different. Our health board part of it, though, was real similar. They had the same statutory duties. A year ago, none of the at least seven counties that had that type of interlocal agreement had gotten, I think one of them had gotten a new interlocal in place. And right now, Matt tells me there's at least 5 in place, and they are all different. They are not just different in how they configure, they are different in their interpretation of what local responsibility and authority is for the board, for the health officer, and it makes it harder for us to gel across that local decentralized system. So that's really the state of where we are. It's not like we haven't been here before, but we're a slightly different place. And that's why it feels the way that it does. And it's you, today's and tomorrow's leaders, that are going to figure out how we deal with this and how we influence it, because we will, because enforcement and rule is not the biggest part of public health. Never was, and it isn't. The last thing, and I'm over time, I know it went off. So I just have a bunch of slides for leaders, and I'm just showing them to you, sort of like, here's the candy shop. The best way, I think, to become a leader is to form those cross-jurisdictional professional relationships at an informal level. Do that. Talk to the person in the other county that looks completely different from yours, and you guys can become leaders on your program, whatever it is. Try to figure out your local board configuration, at least figure out what your county attorney thinks it says. talk with the others. And I think the Institute is doing a really good job on tracking that and opining on that for some of us. To be a leader, if you figured out anything about this, share it. Share it. And finally, and I know you're doing this because many of you were at the confluence. Sorry that I wasn't. And here we are being sponsored by the training center, which is just a miracle to me that, you know, they ask us to speak, they do all the work and we show up and talk. But make sure that you as a leader and future leader go beyond that, and that you are aware of and perhaps participate in the many other institutional ways to meet other leaders and to become a leader. There's the oldest one is the Public Health System Improvement Task Force. Montana has been a leader in public health system improvement. I credit Jane Smiley and a lot of other people, but continues to be. The U of M School of Public and Community Health Sciences, it's another way. The Public Health Institute, where Hillary is at, is one of the newest ways, and they look a lot at the policy issue, which we're looking at now. And of course, our three organizations that have formalized into the confluence, MPHA, MEHA, and of course, our AMFO. If you don't know about all of these, find out, look them over. All of these links are live. You can just go in, look at their webpage, find a project or a person and get involved, because in our early days, we didn't have these organizations except some of the really, we had MPHA and MEHA. You have them, they are structures that you don't have to build, but you can contribute toward their development, and you will get a lot toward leadership. So sorry for a little over time, but I feel very passionately about those pieces.
Thank you so much, Ellen. Really appreciate it. And we're going to move to Hillary now for her piece, and then we'll be back to Ellen.
And that one's shorter, I guarantee you.
Perfect. Thank you, Ellen. I'm gonna do, okay. So the piece I am gonna speak on is empowering staff for leadership. And I like to say this a little bit as like, it's the, like, what are some actual action steps you can take? I feel like every time I hear these presentations, and Ellen gave some great action steps too, it's always kind of for me like that, what's my takeaway? What can I do tomorrow? So I want to talk through the world according to Hillary of ideas on how you could do this work. So 3 specific areas that we're going to touch base on. One is just talking about traditional succession planning, then really about developing skills and competencies in your staff, and then learning from our mistakes, which actually came up in our breakout about like, what have we done wrong and what would we tell others to do or not to do. So I think we're all familiar with the term succession planning, business strategy to pass on leadership roles for one or more other employees. And it's really used to help businesses run smoothly. We hear it a lot from the conversation standpoint of retirement. And that was the piece I was talking about earlier, that we're not always seeing transitions happen from a retirement standpoint. So I would push for more broad conversation about succession planning and this entire topic. And then looking at plans, how they can be for long-term, but also for that emergency piece. Excuse me. So some specific ideas I wanted to come back to. I mentioned some of them when I was doing my introduction piece of ways that you could look at doing a more traditional succession planning piece. One of the most common things that we've seen is to actually look at the title of position. And so whether you're looking at it as deputy health officer, deputy director, those are common terminology pieces we've heard. What those position names start to do are give the idea that this is the backup for somebody. The job description can also state that they're a backup position for a specific person or position. And so even if you can't change names of jobs, maybe just even looking at adding some lines on this person will also serve as a backup for whatever position. That gives your ability when you're talking about change happening and looking at hiring to actually have some documentation, some titles, some ways that you can show that this person or this position has been utilized in a manner that may make sense to do some fast succession movement. The less formal piece is to look at utilizing a backup structure during vacations and sick leave. So I shared at the beginning that when I was at Flathead County, one of the things the health officer at the time, Joe Russell, did was made it very clear when he was on vacation or sick that I was in charge. And I had free reign to contact him, but asked other staff not to make that contact, to go to me first, see if I could help them. If I couldn't, then it would be me who would contact him and figure out what the plan would be. And so just really starting to think about ways that you can start to give that ability to staff. They learn a lot in the process. They start to take on different leadership roles. It can start to help staff, community, whoever it is, view them from that position point too. The other thing I'd start to think about is policies and plans. I shared that Flathead actually created a policy that named the deputy health officer the health officer if the official health officer wasn't available. So that transition of that legal authority. But more than that, I know sometimes it can be hard to have like formal conversations around policies and ways to make this happen. So one of the things I would recommend is your continuity of operations plans. If you're a health department, you're required to have this for FEP deliverables. You may have never looked at it. It might just be your FEP person putting it together in a bubble. It provides you kind of, I see it as like this way to legitimately talk about these topics that maybe your commissioners, your board of health, others don't want to talk about yet. Because you can really start to go through and say, this is just emergency planning. That's all we're doing. We're required to do it. So I'd like to have this conversation with you. We actually have a health department right now, I won't name who, that's been struggling with a medical director and is using the COOP as kind of their reason for bringing this up to elected officials and to start to put in place a backup plan. So just know that there's ways you can talk about it without having to talk about it in a way of maybe utilizing the words like succession. And then, like I said, just talking to the board and elected officials, whether it's through the COOP, whether it's through just looking at long-term planning of even looking at some of the data out there on how long are staff staying at health departments and starting to bring that data to them so that they're starting to think about what does our plan look like moving towards the future. I think just to some extent destigmatizing discussing this and assuming everybody's going to stay for lots of years and will be able to easily plan their retirement. The next piece I really think is about helping staff develop the skills and competencies related to whatever leadership roles you may want them to take on. And so it can be hard to determine what exactly this means. I want to bring your attention to two documents. The first is core competencies for public health professionals. You've probably seen it. I'm not in love with it. I won't say that it's the best document ever written. It can be hard to read, but it does give you some conversation even around like where do you want to grow? If I have a staff person right now, they have 3 tiers in it. From frontline staff to middle management to leadership. And so even if you just start to look at what are some of the transitions between those tiers, some of the things that we would want staff to do, that can be a nice document. The other one that's newer is adapting and aligning public health strategic skills from the de Beaumont Foundation. It's a pretty interesting document, because it starts to look at some things like even diversity, equity, and inclusion, and some topics that aren't addressed in the core competencies. So it's a good place to look when you want to look at moving beyond kind of those normal technical public health skills. When you want to look at somebody who can have effective communication and other pieces. So just know these documents exist out there. We're having lots of conversations about what are the best ways to use this. So we'll continue to share that as we move forward. But it might just give you an idea of where to start. Some other pieces to consider from a competencies and skills piece. Number one is to read your job descriptions. As I shared when we posted for the deputy health officer position, nobody met the qualifications internally. We hadn't set them up to do that. So knowing what you're looking for, maybe you want to keep it, maybe you don't. Maybe you're reading the job descriptions to look at changing them to give an ability for some of the folks internally to be able to get those experiences. If nothing else, you should know if that person leaves, what's written down and what you would be rehiring for, and have an idea of how hard that may or may not be. Looking at individual development plans is really a great way to formally work with your staff. You can use like those competencies to even just pick like where areas they're weak in, where do they want to go, where do they want to grow, and how do we help them along the way. I'm also just a big believer in hands-on. Ellen just mentioned the 3 organizations, MIHA, MPHA, and AMPO. There's tons of opportunity from boards and different groups and sections within those to get some leadership experience. Look in your own community at coalitions, management of different projects. Just different ways that you can start to bring your staff in to learn the skills that you think they'll need beyond what they have now. And I think if we all think about it, we can think of the ones, at least for me, some of the ones that don't always get taught when you're going to school. HR, fiscal, different things like that. So how do you bring people in? How do you say, create your own program budget? Maybe they're not going to nail it the first time, but start giving them an opportunity to do it. Start giving them opportunities to even understand what HR issues may arise. Let them present to boards, elected officials, and do other things like that. So just take a step back and start to think like, how do I start to push other people out there to grow, and then their own interest grows in the positions too. The last piece is really about lessons learned. We have so many of them, right? I mean, we can all think of ones that come into play. One of the pieces I really wanted to bring forward here is what do you wish you had when you walked in the door? So one of the easiest ways we can succession plan, whether it's for your position or anyone else's position, is to start that documentation piece. Do procedures exist? Do you understand what meetings they attend and who the people are that are working with them? Are there filing systems in place? Are there documentation? So starting to even think that through both with yourself and your other staff. Like if you look out your office door right now and you think if that person walked out today, I wouldn't have any idea what they're working on, you got to change something. Like that's just the way it is. And so the more you can take a step back and really start saying, what do we want to just exist about every position? What do we want to know? How do we want to make sure other people know about those pieces is what you want to start to put in place. And I think that's particularly during COVID, as there was loss of staff, I think that's been the #1 lesson learned. We've definitely heard over and over people walking in and saying there was nothing. that's something we can change, and we can easily change it both for ourselves and for our staff. That is all for me.
Awesome. Thank you, Hillary, and for single-handedly getting us back on track.
I know, I was like, I can do it, Emily. I was chatting with her saying, I can get us back on track. I got
You motored. That was awesome. I want to give us just till, like till 12:30 to take that break we would have taken at the top of the hour and get us all hydrated and ready to go for Ellen's last piece. So,
Okay,
it's perfect.
2 messages. 1, accreditation, the process, not the seal of approval. The accreditation process will build leaders. It will build your team. It will build teams of leaders, and it will strengthen your department. I know we're focusing on leadership today, but we're also talking about all the things we need to have in place for when the leader leaves or is not available, whether it's retirement, hit by a bus, or whatever it is. And to have those things in place, we went through, I was not big on policies and documentation. I'm pretty bad about that. But boy, when we got through accreditation, we had really, really strengthened all those things. And then more so on reaccreditation. So that's the first message. The second message is you do not have to go through accreditation in order to get those benefits for you, your leadership teams, your development, or your department. Let's look at the reasons for accreditation, the underpinnings, and they are to improve the public's health, to improve the actual public health system and the practice in that system, to improve ourselves to a standard. So even though we all look different in 56 counties and 8 tribals and blah, 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 there are certain standards of performance that we have met. And then to have the continuous quality improvement. All of those things are available to you by taking on any part of the standards, the domains and the standards for accreditation. And there's now new pathways to take them on and to prepare you for accreditation if you do choose to go. So what I want to basically say is accreditation, or the things related to accreditation, is really a playground. It's like a gym for developing leadership. It's absolutely, go out there, find what piece of equipment you want to learn on and play on it. And rather than look at it as this big, hunking thing. And I want to just very quickly, I'm going to flip through these. These are the formerly 12 domains of accreditation that are now, if you're accrediting after 2022, are now the 10 core standards. So it really covers everything. And we're not going to talk about these, these, but there's so many on-roads. You pick any one of these places and decide to learn about it, improve it, do a project on it, be a leader on it, do it across your department or part of your department. You have improved your leadership and you have strengthened your department so it can withstand the change when the leadership changes. And that's really what matters, right? Not that the leader came or went, but that the department withstands that and carries forward. So these are what used to be the 12, and now it's, and there's of course a lot to do with board development these days because of the law we just talked about and our uncertainty on how that would really play out. It hasn't really been tested. So what I'm giving you is what you give somebody if you're trying to, let's say, you're trying to have a fitness plan. And this is somebody that maybe just hasn't done a lot of activity, or they're recovering from something. And you don't send them to a high spandex gym class with hopping around and doing different steps and feeling like they don't fit. You provide on-ramps, right? You say, let's take a walk around the block. Let's try this. Let's meet somebody else that does this. The on-ramps. So what I'm trying to do here, and this is a second message, is there are a zillion on-ramps for you to move toward the standards and measures of accreditation. There's on-ramps to move toward accreditation. And every single one of them is an on-ramp for strengthening your department and strengthening your leadership and your leadership team. So I'm going to present them in 4 levels. The first are, here's just ideas. Here are some on-ramps. These are your walks around the block for an individual, for any one of you, whether you're in charge of a team or you're going to try to direct a team, or whether you're in charge of a department. You can start with choosing 1 or 2 strategic public health improvement projects. That's all, just something that you really like, or something that bugs you. And to improve it, open up the book on the standards and measures. And if you're going to improve it along the line of the standards and measures. Another is, if you're not already trained in quality improvement, or maybe you are, then get yourself trained as a leader and do that. That is a leadership opportunity. Another, and this is a big one because this one's hard to meet, especially if we're adherents to Public Health 3.0, which I won't go into, you should know what it is or look it up, but is you really have to have very, very good community engagement and very well documented community engagement, and not with proxies, not with just spokespeople for those that experience health inequities. It has to be with the people itself. Get out the standards and measures and just kind of evaluate where you are. The other thing is, you could become the expert in one domain and be a leader that way. So when we approached accreditation, and again, you don't have to do it, but you can approach the improvement aspects, each of us had a domain or 2. And that way everybody had to, do it. But you as an individual, you can say, I really care about the access to care domain, or I care about the enforcement one, or the community engagement, or the board, or whatever. And, pick one up. Second level of on-ramps. These are on-ramps for small groups in your department, even if you have a small department, but especially if you have a larger department. And you might do this in one division, or you might just do it in, in one small group. But an on-ramp would be assessing the health literacy of one of your programs, like go through your WIC program or your nursing program or any of your health promotion programs, and really learn about health literacy and assess your materials and change them. And that would be a huge leadership project, and would address some of the equity issues, and would also, you get that double, whammy, I guess, or that double celebration of you've improved your department and you've improved your services. Another one that lines up very nicely with the standards and domains is cultural competency training. Do it or bring it in. Let's see, another one that lines up nicely with enforcement or rules and investigations is take one set of your rules, your environmental rules, for example, and review them and revise them in accordance with FAB standards. It sounds easy, but when's the last time that you really looked at? And it can be a DEQ rule that you through sanitation are in charge with administering. But do that and find out how old and dusty those things are, but do it in a way that you've actually improved yourselves at a standard. Another really big one is to start working on your client or public satisfaction surveys. And I suggest that you not do this department-wide unless your department is, really, really small, but even then you're probably serving multiple different populations. But that's another way to be a leader and to change your department in a way that it helps bring you up to standard. Now, here are the heavy ones for the whole department, and these are big, but if you're serious about accreditation, then, take one of these on. And I think the one that's getting a great deal of attention in Montana is the workforce development. Have a workforce development plan. And Hillary showed you those competencies. And even though they're hard to read, there are tools online where you can assess where you are with your competencies. You can do something real simple, like every year at performance evaluations, you with your supervisor, or you as a supervisor, you pick one competency that you're going to go get some special training in over the year. It's an on-ramp, it's a way up. Your public health emergency preparedness plans after COVID, you're probably sick to death of them, but how can you move yourself up to a standard? Take what you did capture it, commit it to writing, and revise it so that it fits the standards. And then you've got it. You've got it. QI and PM, if you don't start anywhere else, if you don't think about accreditation, I just can't tell you what a surprising delight really fixing age-old problems was, and how those teams formed cross-department. It was lovely. And then of course the CHA and the CHIP is a really good and important cross-cutting plan, but those are big. Those are big. We also have some formal and funded opportunities in Montana that you can take up. Again, I've mentioned that Montana has long been a leader in public. It's been on the leading edge, particularly for our size state, in public health system improvement. And for some time, the state has offered through Carrie Pry's office the public health system improvement grants. And this is just a really old map. I couldn't get a new map. And we went from like having, 5 large health departments accredited and the rest of the state not looking like as much was happening because they have different resources and sizes. And through these grants, they're usually about 10,000 each, and you apply for them online, you can have a number of projects that are funded, and you've improved your department and you're on the map. The other and last brand new thing is FAB has put out what's called Pathways Recognition, and it's recognition for departments, particularly the types of departments we have in Montana that, they're not going to maybe go for full accreditation, but they want to improve, or they want to think about it while they're improving. So they can obtain Pathways recognition. And I won't go into all of that, but you can, all of these links are live. You can go in and look at it. And Montana, being the leader it is in public health system improvement, Carrie Pride informs me, and maybe many of you know this, that Montana has its first cohort in the Pathways program. I think there were maybe as many as 25, I can't remember the number, but an impressive number of local jurisdictions have joined that cohort, and they were able to give that cohort funding. And the next cohort for going through Pathways will be 2025. And maybe Hillary, who works at the Institute, can tell us more about that. But those are your on-ramps. And I would say, start tomorrow, walk around the block, take one. Thanks.
Thank you so much, Ellen. All right, perfect. Well, thank you so much, everybody. Do we have any questions for Ellen or Hillary as we wrap up? And again, you are free to use the chat if you have a question. We threw a lot of information at you today, but excellent information. I think about this stuff more often now in terms of how I can integrate even the simple thing I think you were saying, and it's come up where if that person were to leave, what would we do? And I'm trying to get better at having records of how I do things, etc., so that we're not left in a lurch. And I think even just starting there is a really nice place to make sure you're documenting things. So I will send out slides, and we will have a recording of this as well when it's ready and edited, and we'll send that out as well. So you can review any of this. And of course, for the folks that had to jump off early, they can have it as well. In the chat, I'm going to put a little survey link to our evaluation survey. We really appreciate you filling those out. That helps us when we're designing trainings, and we'll give that information back to our trainers as well. If you have any questions, again, the contact information of our speakers will be in those resources we send out, so you can reach out with further questions after that. And with that, again, please fill out the evaluation, and I think we'll give you 15 minutes back. That ain't too bad. We really sped up at the end. Excellent. Des, did you have any closing statements?
I did not. I think you summed it up perfectly. And thank you all very much for attending. And thank you presenters for agreeing to bring this training to all of us. So thank you very much.
Yeah.
Thank you. It was fun to see everyone.
Yes,
Thank you, everybody.
definitely.
Thanks. Bye.
Bye.